Thrombocytopenia, low platelets, is all about alphabet soup. Here we're going to have a very low-level discussion about the 4 diseases you have to be able to recognize for the test: DIC, TTP, HIT, and ITP. We're not going to review the pathology in great detail, and I'm not going to explain to you about why and when we do certain things. For that level discussion, watch the intern content, Thrombocytopenia, for more details. This is going to be a drive-by what you have to know for these 4 diseases. First up is TTP. Thrombotic, thrombocytopenic purpura. The pathology here is a formation of a hyaline clot and deficiency in atom TS13. The patient will present as a fat RN. That is, they will have fever, anemia of the microangiopathic hemolytic variety, thrombocytopenia, renal failure, and neurosymptoms, stroke symptoms. What's happening in TTP is these hyaline clots are forming in blood vessels. These hyaline clots are shredding up red blood cells and platelets and forming clots obstructing flow to the distal tissue. That results in the renal failure and the neurologic symptoms. You don't have to be an RN. You can just be fat to make the diagnosis. The diagnosis is going to start with the CBC, which shows low platelets. That same CBC will show you a smear which reveals schistocytes. Schistocytes means microangiopathic hemolytic anemia. Because this is a hyaline clot, you're not going to see changes in secondary hemostasis. You're going to get a DIC panel to make sure it's not DIC. And so you'll have coags, the PT and the PTT. You'll have a fibrinogen. And you'll have the split products or D-dimer. In TTP, the coags are normal. The fibrinogen is normal. And the D-dimer is normal. You'll see how this compares to DIC in just a second. When you make the diagnosis of TTP, low platelets and schistocytes with a normal DIC panel, exchange transfusion is the answer. You do not send out for the atom TS13. You're going to treat this person first. That lab doesn't matter. You use exchange transfusion to take out the bad blood and put in the good blood. Never transfuse platelets. Let's compare TTP to DIC. Disseminated intravascular coagulation is a problem with a fibrin clot. The patient is going to present sick as shit. They are sick for another reason. They have sepsis. They're in the ICU. They're in shock. Then they bleed. DIC is a problem with the body getting out of control. They're so sick, they start forming clots everywhere where they shouldn't. They use up all the factors in platelets forming those clots so that they don't have any left over to form the clots they need. So they bleed. The diagnosis begins with the CBC, where you'll find low platelets. That CBC will allow you to get a smear, which will show schistocytes. In this case, the fibrin clots are being built using platelets, so platelets are low, and those fibrin clots shred up the red blood cells, leading to schistocytes. The platelet count and the smear are the same between TTP and DIC. When you get the coag panel, because this is a fibrin clot, it is going to be deranged. You're using up factors, so your PT and your PTT will elevate. You're using up fibrinogen to form the fibrin clot, so it's low, and the D-dimer will be elevated. This person, the way you treat them, is strictly supportive. You have to fix the underlying disease. And unlike TTP, where you do not want to give platelets, supportive care means transfuse whatever they're not having. If they've got low hemoglobin, give them blood. If they've got low platelets, give them platelets. If they've got low fibrinogen, give them fibrinogen. But the goal is to reverse the shock or the sepsis that tipped all this off. HIT, or heparin-induced thrombocytopenia, is caused by antibodies to platelets. The patient is going to be in the hospital on heparin, some heparin product. And at week 1 or 2, that is 7 to 14 days after being on the heparin product, their platelets plummet. At this point, you don't worry about the diagnosis. Sending off the labs, the HIT antibodies, will take forever to come back. You need to treat them now. Because much like TTP and DIC, they're going to clot where they shouldn't and bleed where they don't have the clot that they should. The treatment is going to be A, stop the heparin. And they should not go on heparin again. But they are going to clot. So you need to put them on an anticoagulant. So you start argatroban and bridge to Coumadin, warfarin. And lastly is ITP. And it is last because it is the diagnosis of exclusion. It used to be called idiopathic thrombocytopenic purpura. Now it is immune. The pathology is, again, antibodies to platelets. And so the patient is going to present, usually a woman with an autoimmune disorder who has low platelets. There is no test for this. It's a diagnosis of exclusion. You must rule out all other causes of thrombocytopenia, and if you have an autoimmune disorder or a history of autoimmune disease in the family, and the platelets are low but everything else is negative, you have the diagnosis. Because it's an autoimmune disease, the treatment is going to start with steroids. This is for an acute flare. If they are critically low, give them IVIG. Hide the platelets from the antibodies so they don't die. In refractory disease, because the culprit in this disease seems to be the spleen, splenectomy is generally curative. And if they fail splenectomy, rescue therapy is with rituximab. This was a brief overview of these disorders. Memorize the chart, get the question right. If you want to practice with thrombocytopenia, check out the intern content for more information. That's thrombocytopenia.